Welcome everyone, and thank you for joining today's webinar produced by Friends of Winship. Friends' mission is to build community understanding and awareness about Winship while raising funds to support its research and patient care programs. And Friends this year is led by Sally Montgomery. Before we get started, I'd like to remind everyone of a few housekeeping items. Although we are in webinar mode, we ask that you do mute your microphone just in case. We are recording this program and it'll be sent out to all of our registrants. If you have any questions during the program, you can use the Q&A button found at the bottom of your screen. And lastly, if you're having any technical difficulties, you can leave the webinar and call in, and you'll be able to hear the webinar through dial-in mode. Today's program is led by Dr. David Frank, Director of the Department of Hematology and Medical Oncology for Emory University School of Medicine. And he's the director of the Innovation Initiative for Winship Cancer Institute. He just joined us on September 1st from Dana-Farber Harvard Cancer Center. And joined by Dr. Frank is Dr. Kristie Blum. She's a professor in the Department of Hematology and Medical Oncology at Emory University School of Medicine, and she's the co-director of the lymphoma program at Winship Cancer Institute. Now I'll turn it over to Dr. Frank to get us started.
Thank you, Amanda. It's a pleasure to be here. I guess I'd like to talk about two things first. One is why I came. So as Amanda said, I had been at the Dana-Farber Cancer Institute and Harvard Medical School for my whole career in oncology. I had been there for several decades. I had great colleagues. I loved my time there. And frankly, I thought I would probably finish my career there. But when this opportunity came up to join the Winship Cancer Institute at Emory, I was really attracted by a couple of things. One was the passion to take the best care of cancer patients throughout the Atlanta metropolitan area, the state of Georgia, the southeastern United States, and really nationally as a leader in cancer care. And the second thing, a core part of my career, has been laboratory research to develop new treatments for people with cancer, new targeted therapies that will be more effective and less toxic. And again, there was a real energy at Emory to be a national leader in this area, to translate advances from the laboratory to the clinic. And these things really appealed to me. And so after many decades at Dana-Farber and Harvard, I joined Winship 22 days ago, and it has been wonderful thus far. And let me just take a moment to tell you about how I got interested in leukemia specifically. So early in my career, I recognized that I wanted to take care of patients with serious illnesses, that I really liked taking care of people and helping them. And I wanted to take care of people who really needed intensive medical care. And certainly the area of leukemia falls in that category. The second thing that appealed to me was the idea that one could just look at a drop of blood under the microscope and with your own eyes understand what is working well and what is not working well with the blood system. The blood system is a beautiful, complex part of our body. And when it works normally, we give it no second thought. But when it doesn't, it leads to very serious illnesses. So those aspects really appealed to me in leukemia. And then the third part was, as I noted, unfortunately, we cannot cure all of our patients with leukemia. The current therapies are often very harsh and intense. And the idea of developing new targeted therapies was particularly appealing to me. So for those reasons, I have been extremely excited to join the Winship family. I've loved my colleagues here so far and being part of this wonderful dynamic group. I love working in the area of leukemia and blood cancers, and I'm happy to have Dr. Blum as one of my colleagues here.
Hello, everybody. So like David, I'm somewhat new to Emory. I've been here just a little bit longer. So I started in 2017 and was previously at Ohio State and there for about 14 years, really specializing in lymphoma and directing their lymphoma research program. So I actually came to Emory for many of the same reasons that David outlined. It is an incredibly large and growing place with a lot of opportunities for exciting research. And so those opportunities for advancement and really increasing what we know in lymphomas and doing large trials appealed to me. As David said, the people are really what make Emory, and I'm still struck by this today, that how many great nurses, how many great nurse practitioners who have worked at Emory for many, many years and still love the place and love taking care of the patients, and they're really inspiring. So that's continues to keep me here and keep me excited about working as part of Emory's faculty. In terms of what got me interested in lymphoma, you know, it actually, I come from a family with no physician, so I was the first medical person in our family, but I have a much younger sister. And I remember when she was born, being in the hospital and being inspired by being in the hospital and seeing all the different physicians and the staff there that were taking care of her and my mother. And then over the years, as I went to medical school, residency, fellowship, really encountered a lot of great mentors who got me interested in oncology. You know, way back in medical school, the same thing, looking at blood smears and being able to diagnose lymphomas, leukemia from blood smears was really interesting. And then as I got into residency and fellowship, I had many great mentors who really helped spark my interest in lymphomas. And part of the reason I like taking care of the disease is it affects a wide spectrum of patients of varying ages. So we see patients from 18 to 80 with lymphomas. They affect all organ systems. And so the presentations of people are very unique. And the other thing that's exciting, and I'll show you as we go along through today's talk, is there is a ton of advances in lymphoma. And even back when I started, there were a lot of opportunities for new drugs being developed, new opportunities for research. And so the number of advances in the care of lymphoma in these last 20 years is really impressive and keeps me inspired to continue this work. So if you want to go to the next slide, I'll show you quickly actually, David, did you run through this slide yet, or the faculty here?
Thank you, Kristie. Let me just take a moment to note that right now we have 8 faculty members who focus exclusively on leukemias. There are a number of abbreviations here. There are a number of subtypes of leukemias and variations on leukemia. Each person has a particular specialty. Dr. Panaskalsis, as with me, both see patients and run a laboratory to try to tie in advances in the lab to patient care. But these are our faculty focusing solely on leukemia. And Kristie, do you want to talk about your colleagues in the lymphoma area?
Yes, that sounds good. So the next slide. Yeah. So we also have a number of lymphoma specialty faculty. We all see slightly different subtypes of lymphoma, but you'll see Dr. Cohen and I both co-direct the lymphoma program. Jean Koff is one of our newer faculty. She specializes in immune deficiency lymphomas. Dr. Hefner sees CLL and Waldenstrom's. Both Dr. Oriana Noya and Dr. Romanchek started with us within the last year or two, and we're really excited to have them joining. Dr. Oriana Noya is focusing on kind of elderly lymphoma, so those in patients over 65. Dr. Romanchek is looking at our immune and CAR T type therapies. And then Dr. Chang, who also specializes in CLL and indolent lymphomas. And that's really our B-cell lymphoma group. We have 2 excellent T-cell lymphoma faculty, Dr. Lekowitz and Dr. Allen, and they take care of both of our cutaneous and our systemic T-cell lymphoma patients. Next slide. Are you able to? Yeah, thank you. So just as a quick introduction, and I think then we're going to go into some specific questions about leukemia and lymphoma. I think one of the things as people hear about lymphoma that they don't really recognize is that lymphoma isn't just one type of cancer. It's really actually about 40 types of cancer. It's broken down into 2 main types, Hodgkin lymphoma and non-Hodgkin lymphoma. Within Hodgkin's lymphoma, there are really 2 different types that get treated differently and present differently. And then within non-Hodgkin's lymphoma, we break these down into what we call B-cell lymphomas or T-cell lymphomas. But within each of those categories, there's a number of different subtypes. And what is difficult and challenging is they all present differently, they all have different prognosis, and they're all treated differently. And I just list, again, a couple of different types here, the more common ones on this slide. But again, just to give you a big perspective of this isn't just one disease, this is really 40 different diseases. And then one more slide, and then we can maybe get to our questions. And so as I alluded to earlier, part of what excites me about lymphoma care is just that there really are a wealth of new drugs that have been approved and are in development. And again, these are just listed here with their classes, and these are really the ones that have just come out in the last 10 years. And a number of these we'll talk about kind of as we go along today, but a number of these are new immunotherapies that work for these different subtypes of lymphoma. And David, you probably want to jump in here and talk a little bit about leukemia and the new drugs as well.
Yes, so the treatment for leukemia has always been fairly harsh. And traditionally, the drugs that we use kill normal blood cells as well as the malignant or leukemic blood cells. And because of that, the side effects are intense. Patients often require weeks and weeks in the hospital for their therapy due to the harshness of the therapy. And so the clinical trials that we're really interested in and participating in are really based on understanding some of these new molecular abnormalities that have recently been diagnosed in leukemias, mutations in enzymes that have all kinds of long names like isocitrate dehydrogenase or IDH. But the key point is that rather than kill all of the cells and hope that we're killing more of the leukemia cells, we can really target the abnormalities that are unique to the leukemia cells. So the clinical trials that we're participating here at Emory include trials that are open nationally, as well as those that we're looking to spearhead ourselves that target these unique mutations found in the leukemia cells.
Thank you both so much for sharing that overview. We do have some conversation that we'd like to engage in right now with some questions. And the first one is a great one based on your last comment, Dr. Frank. Please share with us what clinical trials are available to your patients in your areas of expertise.
Great. So I think we're going to take each of these questions, and David and I will alternate. So I'll address sort of lymphoma trials, and then David will address leukemia trials. For lymphoma, we actually have a number of different studies. And again, it kind of gets down to all those different subtypes of lymphoma that I just showed you. These trials address each subtype individually, but we have very large, what we call cooperative group or national studies addressing frontline treatments, so first treatments for many of those types of lymphomas. But we also have sort of newer drugs and smaller studies with these brand new agents for patients who have lymphomas that recur and maybe aren't treatable. And we have a number of trials kind of looking at immune therapies or options, and we'll talk about CAR T as we go along, but options for CAR T in these lymphomas. So we really kind of span all the different types of lymphoma, but also the different stages between initial treatment toward treatment if it were to come back, or treatment even if it comes back a second or a third time.
And similarly, in leukemia, as I noted, we have a number of trials, one of which is a national trial called BEAT AML, which is really based on doing molecular analysis of each patient. So we talk about precision medicine, not treating everyone the same way in a cookbook type of manner, but to say what is unique in the leukemia that you happen to have, and how can we target that specifically? So we adapt the therapy to the specific molecular type of leukemia that each individual patient has. And I would mention one other reason why this is really important. So I mentioned that the standard treatment for acute leukemia is intensive chemotherapy, requires weeks in the hospital. But it turns out that the median age of patients with acute leukemia is around 70. So for younger patients, they can tolerate this type of therapy, but we have a large cohort of older patients who may have other illnesses and so on, who can't tolerate the standard, what we call induction therapy. So that makes it even more important to have these novel clinical trials that involve targeted agents with much less toxicity, which I think will be much more valuable in particular to this larger, older group of patients. And again, we're trying to be leaders in that area as well.
And does immunotherapy play a role in treatment, Dr. Blum?
Yeah, so there is a lot of sort of new research, but even new drugs that are immune therapies that are approved in lymphomas. One of the very first, what we call immune therapies, was a drug called rituximab, and now it's been around for probably over 15, almost 20 years for the treatment of lymphoma. And it was sort of one of the first targeted therapies targeting the immune system. But since then, there have been a number of drugs, from drugs like checkpoint inhibitors, things called nivolumab, or pembrolizumab that are particularly active in Hodgkin's lymphoma. But even more recently now, the development of CAR T, where we actually can take a patient's own immune cells, their T cells, engineer them in the lab to actually attack a lymphoma better, and then reinfuse those in the patients. And those have a lot of activity and are approved for the treatment of aggressive lymphomas. So there's actually a number of types of immunotherapy, and we use all of these different types in the different types of lymphoma as part of frontline as well as recurrent treatment.
And, the area of immune therapy for leukemias is actually quite interesting. So as many of you know, going back decades, we understood that some patients benefited from receiving a bone marrow transplant, an infusion of bone marrow from an unrelated person, from a related or unrelated person. And one of the things that we found from this was that sometimes this new immune system, which we were infusing into a patient, could actually attack any residual leukemia cells left behind. And that was one of the first clues that actually our immune systems, if treated appropriately, might be able to attack leukemias. There is also a downside to that, that sometimes the new immune system can attack normal healthy tissue, a condition we call graft versus host disease. So there's been a lot of effort in trying to tease apart how we can activate the immune system to kill the leukemia cells, which could be incredibly beneficial because the immune system can go everywhere in our body, but not to cause harmful effects on normal cells. And so a great deal of the work that we're doing now is looking at ways to unleash the immune system, preferably a patient's own immune system, to attack the leukemia cells, leave normal cells unharmed. And we're very optimistic that this might be a useful way to move forward. I could also say that some leukemias are relatively resistant to getting the immune system activated. And one of the things that we're looking at in my laboratory and at others is how to make the leukemia cells more visible to immune cells and more susceptible to being killed by immune cells. And we're very optimistic about this approach as well.
Back to Dr. Blum, how do you see lymphoma treatment changing in the next 5 to 10 years?
Yeah, I think there are a number of ways, and that's one of the things that remains exciting about the care of lymphoma to me. So as we talked about in the last question, there are all of these new immune therapies that are under development, and we are adding them in new ways to treatments for patients for lymphoma. So one thing that I'd particularly like to see happen, many of these immune therapies are really effective, and traditionally for things like Hodgkin's lymphoma, we've been giving what we call cytotoxic chemotherapy. It's sort of indiscriminate chemotherapy. It kills the good and the bad cells, which is why people have side effects. And we hope that these immune therapies, which look really effective, may actually replace some of those cytotoxic treatment, or even let us reduce the number of treatments that we give people. We kind of always traditionally, for example, would give 6 rounds of chemo to somebody with Hodgkin's. And what I'd like to say, I don't think everybody needs that much. So with these new immune therapies, we may be able to reduce that number, get people on with their lives a lot faster, get them through their treatments a lot quicker. So I think that's one way that we'll probably see things change. There is a lot of new data coming out about the genetics of different types of lymphomas. So traditionally, for example, there's a type of non-Hodgkin's lymphoma called large B-cell lymphoma. It's one of the more common types. And we never really understood, the cure rates with normal chemo is about 50 to 60%. But now with all the genetics coming out, we are recognizing more and more within that category, there are probably subcategories that respond better to some chemos than others. So really developing more of what we call kind of a precision technique to guide your treatment and find out what mutations does your lymphoma have and how can we best target those from the outset of treatment. And then the last thing that I'll bring up is I think we are learning more and more ways to detect when lymphomas come back and detect them early. And so there's a lot of new tests with just a blood sample where you can actually see the genes from the lymphoma in the blood, and you can detect the lymphoma coming back faster than a scan can. And it can also predict who's a little more likely for it to come back. So using some of those tests, a simple blood draw, to say, this patient may be at higher risk for this coming back, we need to add on a couple extra therapies. So those are really 3 areas that things will probably change. There are a lot more drugs and targets coming out. So there are many different things that I think are going to evolve over the next 5 to 10 years.
Dr. Blum in the leukemia space?
I think in the area of leukemia, it's very, very similar to what you just heard for lymphoma. But again, I want to stress that the current therapy for acute leukemias were actually developed in the 1970s. And they are relatively crude, and even to this day, where we use very toxic drugs to kill almost all of the blood cells in the body, the goal being to kill more of the leukemia cells and try to have some of the normal cells persist. And it is so intensive that it's kind of a life-threatening journey just to go through that chemotherapy. And so what I hope in the next 5 or 10 years is that, just as Dr. Blum was saying, that we will target the abnormalities in these leukemia cells. We will not take this slash and burn approach of trying to kill almost everything, just target the abnormalities in the leukemia cells, leave the normal cells unscathed. I think that will be much less toxic, hopefully even more effective. And so again, targeting specific mutations in leukemic cells, activating the immune system to kill leukemia cells, that I think is really going to be on the forefront of new approaches that we're going to be seeing in the next 5 to 10 years.
Thank you. Dr. Blum, speaking again to your point about genetics, what role does family history and genetics play in diagnosis and treatment?
Yeah, so actually very little. Most lymphomas are sporadic. About only 5% of the cases you'll see a family history. So 95% of the time people don't have a family member who had lymphoma. In those few that do, it's not usually like a parent to child type of thing. You'll see cousins that might have Hodgkin's or something called CLL, and you'll see different lymphomas in sort of second and third degree relatives. So it's not very common to see a genetic lymphoma.
And similarly for leukemia, it's not as common to see that type of genetic association with acute leukemia, though there are some exceptions. There are, for example, families who have an increased risk of myelodysplastic syndrome or myelodysplasia, this MDS you saw on a previous slide, and that can predispose to acute leukemia. We know certain other conditions like Down syndrome is associated with an increased risk of acute lymphoblastic leukemia. But as Dr. Blum indicated, it's kind of inherited changes that are acquired by a person in life rather than from one's parents. So we know that exposure to certain toxic chemicals or radiation can increase the risk of acute leukemia. And actually, we're now getting better at detecting these types of abnormalities in the blood in people even before they develop leukemia. And I think one of the really interesting areas in leukemia research and leukemia care in the future will be having these very sensitive tests to find mutations in the blood of healthy people and trying to find ways either to monitor them more closely or actually prevent the development of leukemia. And I think that way, by tying in the understanding of these genetic abnormalities, we can hopefully prevent or treat more effectively people who do develop leukemia.
Thank you. So for our survivors, what are some of the long-term effects of leukemia and lymphoma for those that have gone through treatment and survived?
Yeah, for lymphoma patients, it depends a lot on the treatment that they got and the age that they were at the time they received it. And so, for example, there's a lot of research into sort of late effects for Hodgkin's lymphoma survivors. And much of this has to do with sort of older types of chemotherapy that we did or older types of radiation. So for some patients who got treated 10, 15 years ago, there are risks of things like heart disease because they got radiation to their chest, or second cancers like breast cancers, again, because there was radiation to the chest and the breast tissue when they were young. But a lot of that's changing, and we're learning more and more. We have newer radiation techniques. We have less toxic chemo that have kind of less side effects. And so what we're seeing now is sort of risks for survivors are probably going to be different in 10 to 15 years. But again, a lot of it comes down to the therapy people received.
I'm glad that you brought up the issue of survivors. And actually, before talking about survivors of leukemia treatment, I actually want to talk about some of the patients who come to us who are survivors of other cancer. So I mentioned a moment ago that one of the risk factors for acute leukemia is exposure to chemicals that can damage DNA, that can cause mutations. And so a fairly big cohort of our patients who present with acute leukemia had been treated in the past with chemotherapeutic drugs for other cancers. So I think the whole idea of survivorship and monitoring patients after their acute therapy for cancer is really important. And that's one of the things I know has been a focus here at Winship, and I think is very valuable. For patients with leukemia who undergo treatment, there are a variety of long-term complications. So Dr. Blum mentioned heart damage. One of the drugs that we commonly use for the treatment of acute leukemia can, when given in substantial doses, cause a weakening of the heart. So an ongoing analysis of heart function is really critical. And again, one of the things that really attracted me to Winship and the Emory community more broadly is a very close collaboration that we have, for example, with cardiologists who are particularly interested in patients who had previously been treated for cancer. And having that type of specialized expertise is incredibly valuable in dealing with these complex situations. So those types of monitoring and close follow-up for survivors is extremely important. A second group are patients who've undergone bone marrow transplants. So that can lead to a whole other set of complications. As I mentioned, when you receive a new immune system from someone else, although an advantage can be that it can detect and kill any residual leukemia cells, a potential disadvantage is that this new immune system can attack normal healthy tissue, so-called graft versus host disease. And so that can lead to a number of other complications in the short term and even over periods of years. And again, that type of ongoing longitudinal follow-up is as important as the immediate therapy. And then finally, I just want to mention one other component of survivorship that I think is very important, and that is the psychological and sociological effects of going through these very difficult illnesses, going through prolonged hospitalizations, having a number of side effects potentially. This can be unbelievably stressful for a human being in general. And so providing ongoing psychosocial support, social work, psychologists, psychiatrists as needed to help support patients during the longer term as they recover and go on with life is equally important. Oftentimes we focus on the immediate disease, on the leukemia or the lymphoma, but oftentimes people can struggle with other conditions related to the journey that they went through. And I think supporting people throughout all of these various modalities is equally important.
That's such a great point, Dr. Frank. Thank you for sharing all of that. So moving on to sort of a different, slightly different topic, who are some of the new recruits to the Leukemia and Lymphoma program, and what makes their work exciting? Of course, Dr. Frank, you are a very new recruit to Winship, but would love to hear some of your ideas around the leukemia space. And let's hear first from Dr. Blum about the lymphoma space.
Yeah, so I think I showed you on that first slide where we showed our faculty, several of our newest faculty. I'll start with Dr. Jean Koff. She's been here now about 4 years, and she actually has a translational lab and sees patients. And her work is really focused on immune therapy or immune suppression related lymphomas. So we do know that people who have a history of other immunologic disorders like rheumatoid arthritis or lupus have a higher risk of lymphomas. And we're not exactly sure why that is. We also see lymphomas in people who've had transplants, like a kidney transplant or a lung transplant. And so a lot of her work is really focused on understanding some of the mechanisms of that type of lymphoma, which occur and are somewhat different from the other lymphomas that occur in patients who don't have this history. So that's Dr. Koff. Dr. Allen, who you'll see at the bottom of the screen, she's also now been here about 4 years and came from Northwestern. And she really focuses on both Hodgkin's research, but also T-cell lymphoma research. And she has really built up our cutaneous T-cell lymphoma, which is a type of lymphoma that involves the skin, causes very difficult rashes and skin damage to really manage and increases risk for infections. So she's really built out that program and is collaborating with some of our radiation oncologists to think about new therapies for those patients that combine radiation and chemotherapy for them. And she's also presented at several national meetings adding new drugs to Hodgkin's therapy. So we're really excited to have both of them here, and they've been quite successful in these first couple of years. As I mentioned earlier, Dr. Oriana Noya, who's there on the second line, he started about a year ago and is in his second year with us. And he is really interested in how do we tailor therapy for patients who are over the age of 60 or 70, really, where the therapy, as Dr. Frank was mentioning, may be really difficult and may be a little too harsh for them. But every person's different. You don't just go by their age. You know, some people are much more active at 75 and have fewer medical problems than others. And so looking at how do we gauge who can tolerate the most aggressive therapy and who can't, and what do we need to dose reduce or adjust that therapy is really some of his work and his areas of interest. So it's going to be exciting to see him develop that over the next couple of years. And then our newest member is Dr. Romanchek, who is just starting this year. But he was a fellow or a trainee with us here at Emory, so we've known him for a couple of years. And he takes excellent care of patients and is really interested in sort of transplant, but more importantly, cell therapies like CAR T therapy for lymphoma, and is going to continue to help us really expand that research program.
And perhaps, Scott, if we can go to the preceding slide, I can just mention very briefly about our leukemia faculty. So, you know, as Dr. Blum was kind of indicating, you want a range of expertise. You want to have good young members of the faculty. You want to have senior members of the faculty with experience. So in the last few years, for example, we've recruited Dr. William Blum, who heads our leukemia program, a nationally recognized leader in leukemia, phenomenal recruit to have someone with that type of expertise and prominence as part of our program. Similarly, Dr. Panoskaltsis, who is an outstanding clinician, also who runs a laboratory dedicated to research in the area of leukemia, who can translate advances from the laboratory to the clinic. These are two more senior people who have joined our group who really add a tremendous amount of gravitas and experience. We also have younger faculty members like Dr. Papadan Tanakis, Dr. Hunter, who have gone through training more recently, outstanding clinicians, outstandingly well-trained, extremely enthusiastic, looking forward both to taking care of patients as well as academic discovery moving forward. And I would broaden that, you know, Dr. Blum alluded to this, she and I talked quite a bit about recruiting new faculty members. So we have wonderful people at Emory. We're really blessed with phenomenal physicians here, but there is a huge demand, unfortunately, for leukemia and lymphoma specialists here in our Atlanta community. And so we do need to expand, and we do need to expand our faculty. And we are continually trying to recruit really the top trainees coming out of the best programs across the country to come join us at Emory. And that's really part of our future plans as well.
Thank you. So speaking of that greatest need, what are some of the other greatest needs in the leukemia and lymphoma space? Dr. Blum?
Yeah, so there's always needs in our space. I think we are looking to recruit new faculty and to be able to support those faculty. For example, in the lymphoma program, while we have many investigators that see something called chronic lymphocytic leukemia, we really could expand our research in that area. So we're looking for faculty who want to expand that. We have a number of areas that we want to expand the number of resources we have. So I mentioned, again, kind of looking at those patients over 70 and really trying to determine who's best suited for chemotherapy, or, you know, how do we tailor that chemotherapy? So we're looking to expand that program, get not only just social workers, but dietitians and other ancillary services that really can support that population. I am particularly interested in what we call the adolescent and young adult population. So lymphomas, for example, affect patients from the age of 12 all the way up to their 80s. And so we really cross both pediatrics and adults. And that age group of patients, sort of 15 to 30, they have a lot different needs than some of our patients that are older or the younger pediatric patients. So if you can imagine you're a 16-year-old, you don't really fit as well into a pediatric oncology clinic. but you don't really fit as well into an oncology clinic either, or an adult oncology clinic. So looking at developing specific resources for them, because they need help in terms of, a lot of them are coming off their parents' insurance as they go to college, so they need help funding, their care. They're just starting new jobs. They may have young children and need childcare support while they're trying to go through their chemotherapy. So the issues that affect that whole patient is a lot different than the much younger or much older patients. So we're looking at, can we build a program that really supports them, again, with the social workers and the fertility specialist and all the different needs that they may have that might be different than an older patient population. And then the other, big thing that we're always looking to support is clinical trials require a lot of funding. And sometimes we'll get support from pharmaceutical companies, we get support from the National Cancer Institute, but there's always small pieces of those studies, small ancillary studies we want to do to advance the research. Sometimes these drugs are brand new and the pharmaceutical companies don't want to test them in uncommon lymphomas. So having support to run some of these trials in rare lymphomas, like what we call hairy cell leukemia or a primary mediastinal lymphoma, those are areas that pharmaceutical companies don't want to spend as much time on because there aren't as many patients affected by them. So funding some of those trials for those less common diseases is really important as well. And David, I'll let you take it over from there.
I think Dr. Blum really hit many important areas that apply equally well to leukemia. Again, clinical trials is how we advance our care of patients. This is how we know what the best treatment is. Some of these studies are supported by pharmaceutical companies. There are many great ideas, though, from our faculty that will not be supported by pharmaceutical companies, but they're really important to advancing care for our patients. So clinical trials is a huge unmet need. I would mention two others briefly. One is, as I had noted before, that we can now detect very subtle mutations in the blood of otherwise healthy people. And we know that these predispose to the development of leukemia and other conditions. And so we're really looking to develop this area in which we can take normal people and try to keep them healthy longer. So we know that among the big advances made in breast cancer was early detection, mammography, and studies like that. So again, to try to either prevent the cancer from ever developing or catch it very early. And I think that type of approach, which we're really on the cutting edge of right now, is something of great value. And then the third thing I would mention that I've spoken about earlier is advances from the laboratory going into clinical trials in our patients, getting samples from the patients and bringing that back to the laboratory. The so-called translational research, which again is where I think we're going to make great advances. Dr. Blum and I, for example, have been talking about a drug that we identified in my laboratory that can inhibit a target that's commonly abnormal in lymphomas, and looking ways to collaborate on that way. So trying to support young physician scientists who both take care of patients and run laboratories to have that back and forth between discovery and patient care. That's kind of the third major area I really look forward to supporting.
Thank you so much. So you've kind of touched on this, and great segue. How has philanthropy helped you be nimble in your research?
Yeah, so again, I think kind of just reiterating some of the things that we mentioned before, that the philanthropy really helps us sort of do this translational research. We may get the pharmaceutical company to provide us a drug for a clinical trial, but they may not have the funding or the ability to support us getting the additional blood samples, for example, to see, do early detection. Are we eliminating the cancer cells from the blood very early? Something we call MRD assessments. Or can we look at the sequencing of that patient's tumor and see, is it changing with the drug? And so to be able to fund some of those studies that go along with the clinical trial, so we can see how the drug is changing that patient's cancer, how it's helping it, or maybe how the cancer is getting resistant to it, so that we can figure out better ways to really dose that chemotherapy drug or to combine it with newer agents. So I think that's a huge area that philanthropy has helped. And again, as I mentioned a little bit earlier, again, kind of funding some of these things that are smaller, less common diseases that maybe the pharmaceutical company just really can't support yet, or the NCI is not ready to support, and helping us get those off the ground, because we need to make advances across all lymphomas, not just the most common ones.
I do think that's a great question, Amanda, and as Dr. Blum just talked about aspects of clinical research, I'll complement that with talking about laboratory research. So as I mentioned, the work that we do is really dedicated to making new advances based on a molecular understanding of leukemia and other cancer, and then translating that into a clinical trial, into a treatment for our patients. So most of the work in our lab and the labs here at Emory and across the country are funded by the National Cancer Institute. Now, grant applications to the National Cancer Institute, only about 10% of those are funded. So it takes months to prepare an application. Very few are actually funded. And even when funding does come, it takes about almost a year after the application was put in to actually receive the funding. So again, I'm grateful for the funding from the National Cancer Institute, but it's kind of a slow and ponderous type of process. Support we've received from Philanthropy, however, has allowed us to act very rapidly on new ideas, to get experiments done rapidly in the lab, to get new ideas translated from the laboratory to clinical trials much more quickly. So while we're grateful for the support from the National Cancer Institute, philanthropic funds has really accelerated the rate at which we can take a new advance from the lab and bring it to our patients.
Thank you. So to help our guests better understand a little bit more around philanthropy in this space, I'm going to ask my colleague Jessica to give us some background and some more information. And Scott, if you will pull up our slide for this next section. Thank you, Jessica.
Thanks, Amanda. And so, I don't know that I can speak any better to this area than you've already heard from Dr. Frank and Dr. Blum, but I will do my best to sort of sum it up again. The first kind of category in which you could become involved philanthropically at Winship is sort of the program and research category. Investing in pilot programs, innovative studies that can really accelerate, as you've heard from Drs. Frank and Blum, the process by which these scientific research findings are translated really from the bench to the bedside and getting to patients faster. Another way, of course, to provide support is by donating directly to the departmental funds, which really go towards the top priorities in care, research, strategic initiatives, and the main kind of strategic and overall arching priorities of the departments. Sort of the second category that we think of, which again was spoken to so eloquently already, is really investing in people. As the only NCI designated cancer center in Georgia, we are competing to recruit and retain the best of the best. And we're competing with the best institutions across the country to do this. Recruitment and retention requires a lot of investment, and partnering in this area philanthropically with Winship by investing in people here ensures that if and when you need it, you will be taken care of by the best leaders in their fields right here in Atlanta without hopefully having to travel across the country. Finally, a third way to become involved philanthropically at Winship is by investing in physical spaces. So cutting edge equipment, great physical space, those things are imperative to be able to conduct cutting edge lab research and conduct these trials and pilot studies. And of course, for patient care, we know that the care environment can impact a patient's overall well-being, their outlook, and sometimes even their receptivity to care, which is why we are building new spaces, including the tower, the Winship Tower in Midtown, and adding efficiency to existing spaces so that patients have as little burden as possible accessing their care, and hopefully can go to one location, have their doctor see them there, and not have to drive all over Atlanta, as much as we all enjoy that. If you would have any questions about any of these areas or would like to learn more, I would love to connect with you. And I think my contact information is on the next slide. Thank you so much.
Thanks, Jessica. Before we get to that, Scott, you can cut off the slides at the moment, but I'm going to move now to our Q&A section. We do have some questions from our audience. The first one is, if you could share, what's the typical cost of a clinical trial?
I would say it varies, per trial and the size of the trial and what we're trying to collect in terms of whether it be radiology scans or blood samples as part of that trial. I would say a ballpark that we will generally give as we're talking to pharmaceutical companies about developing studies is that it can cost as much as $10,000 to $15,000 per patient. So if you have a study with 10 patients on it, it's going to cost $100,000 and more, depending on that patient. But even when we get funding, to support that, often different pieces of that trial are funded in different ways. So as I mentioned, sometimes the company will provide the drug, but we still need support to do those translational studies in the lab. And so we'll look to philanthropy or other sources like grants to get support. So a trial may actually be funded by 4 or 5 different groups to really get it off the ground.
Thank you. Are there any statistics you can share that show progress in treatment from the last 10 years or so? For example, life expectancy, length of remission, patients treated at Winship clinical trials, et cetera.
David, you want to go first?
Well, certainly overall life expectancy for many of the diseases we've talked about has improved. And some of the treatments we're talking about have been pioneered in patients whose disease has progressed despite all of the best therapies that we have. So the addition of new therapies, like Dr. Blum mentioned, CAR T cells, has really saved people who might otherwise have died of these diseases. However, we still have a long way to go. So progress is most definitely being made, but people are still dying of these diseases. Overall, in the United States, 1,500 people die every day of one form of cancer or another. And again, so while I think we give outstanding care, while we're talking about clinical trials to advance the field, we still have room to go in cancer in general and blood cancers in particular to make advances. However, our accrual to clinical trials continues to increase. The number of patients being seen at Winship year to year continues to increase. And I think this gives us an opportunity to have a greater impact on more people as we move forward.
And I would just jump in to kind of add a couple specific examples just from my own career. So again, just under 20 years here. There's a couple different types of lymphoma. There's something called mantle cell lymphoma, which is an incredibly aggressive lymphoma. When I started 20 years ago, the average survivals that were quoted were under 5 years. And now, because of advances through clinical trials and bench research, they have a number of new drugs, including oral pill type drugs for mantle cell. And the last updates show average survivals exceed 10 to 15 years. And now we have CAR T now available to that same group of patients. So over the next 5 years, if we look at those survival numbers, they're going to be even longer. So I think that's a really good example of just the advances made, in a short period of time based on clinical and translational research.
Thank you. Next question, is there any hope for developing a vaccination to prophylactically address leukemia or lymphoma?
Well, I guess I can talk about that first. So I don't think that we're close to getting into a position where we can take healthy young people and give them a vaccine to prevent these diseases. However, as I mentioned, I think we're getting better at detecting conditions that may increase the risk of progressing, for example, to leukemia. And I think we could potentially look at that subset of people at ways to prevent it from ever evolving into a full leukemia. And so again, if we could do that, I think it would be incredibly powerful. And there are potential immune strategies that can be used. So again, I think this points up, one, we need to do research in this area of early detection. Two, we need to do research in the area of immune approaches to leukemia and other blood cancers or preconditions for them. And three, we have to consider clinical trials to test new approaches in rigorous ways to advance these fields.
In lymphoma, actually, there was a lot of interest in vaccines about 15 years ago, and lots of studies actually done trying vaccines. And these were they were only effective in about 10% of people. So while they worked really well in that 10%, 90% of the time they weren't really that effective, which is why they haven't gone a whole lot further. But what we're focusing on now is looking at that 10% and what was it about their immune system? What was it about their immune response that actually made that vaccine work? So really kind of looking at that and trying to figure out how to engage the immune system in a better way And perhaps using a vaccine in combination with another immune therapy will be a direction we'll take in the future.
Thank you. Any new insights into what causes leukemia and lymphoma?
That is a complex area. So I'll just focusing on the leukemia part for a moment. Again, we do know that exposures that damage DNA, again, because our blood cells, especially our stem cells in our bone marrow that reproduce all of our blood cells over our lifetime, they're with us from the time we're born throughout our lives. And so anything that damages the DNA can in fact predispose to leukemia. And so things like radiation, we know certainly can do that. But again, chemicals, toxins of that nature can predispose to leukemia. I think the environmental protections we've been putting into place over decades have been very important in reducing exposures, but these are the main things that we know can definitely be associated with leukemia. As I mentioned, we have a fairly large population of patients who've received chemotherapeutic drugs for earlier diagnoses of cancers. So again, in general, if we can decrease the use of these drugs as much as possible, I think we can have a meaningful impact at decreasing the incidence of new cases of leukemia.
And in lymphoma, it's very similar, that it is likely an exposure, although we don't know what that exposure is for every patient. So there are patients who have been exposed to radiation as a child, or even, radiation disasters, or Chernobyl victims, for example, have higher cases of lymphomas. That's not really the case for all the lymphomas we see. It's a small percentage of them, but also people who have immune deficiencies have higher lymphoma rates. So again, those who've had a transplant for a solid organ, like a kidney transplant, are on immune suppressive therapies, they get more lymphomas. Patients who have had HIV also are at risk for lymphomas. And again, it has to do with the immune suppression. But these are a very small number of the cases that we see. And for the majority of people, we don't really know exactly what they were exposed to that causes that lymphoma.
Thank you. Here's a really specific question. Now that Dr. Klisovich, I'm not sure if I'm saying that correctly, is leaving, what are the plans for a new CML specialist?
That's a very astute question. So, we're talking about recruiting our phenomenal faculty. Unfortunately, some of our phenomenal faculty are recruited elsewhere. And we're very sorry to be losing her, though she's been a phenomenal contributor to our faculty. Interestingly, CML, or chronic myelogenous leukemia, is a disease I'm very interested in. And that is a phenomenal example of a disease that really was incredibly life-threatening in most patients, that unless a patient received a successful bone marrow transplant, it could be fatal in several years. But a specific abnormality, a molecular abnormality, was defined in which two chromosomes break and join each other. And there's actually a beautiful sculpture here at Emory that depicts this event. And once that was appreciated, a drug was developed. Now we have several drugs that target that specific mutation. I was fortunate to be part of those initial clinical trials about 20 years ago when I was at Dana-Farber, that took a disease that could be rapidly fatal and made it eminently treatable. So that may be a long answer to say that that is one of the diseases that I'm particularly interested in taking over and taking care of patients at Winship as we move forward.
Thank you so much, Dr. Frank. I'm going to wrap up our Q&A at this time, and I'm sorry if we were not able to get to all of our questions. Scott, if you'll throw up our last couple slides here. I would just want to thank again, Dr. Frank and Dr. Blum. We've learned so much from you today. We're just so grateful for you sharing your time with us and sharing your expertise. If you have any questions about any of the information that you've learned today, or you have interest in learning about philanthropy and how you could support these opportunities, you can reach out to Jessica. Her contact information is here. And again, we thank you all so much for attending today, and we hope you have a wonderful afternoon.